Our second Sloan keynote will be delivered by Professor Julian Tang, who actually started his career in Chinese University of Hong Kong, and then coming from the background as a medical doctor and bench scientist in the medical biology area. He's now coming today from University of Alberta, where he currently works in the faculty of medical virology. Julian?
Hi, thanks, Jenny. And thanks to my two predecessors who've actually covered pretty much all the factual stuff that I need to cover. So it's quite good. I don't have many facts in this talk. It's really a lot of questions. Special thanks to you, Guo, for organizing this conference. You know, it's our 10th anniversary, you, Guo. The email I first sent you after the Ammo Gardens study. So we've known each other for 10 years and it's been great. Okay, so I'm going to take you on a fantastic voyage as a virus from a source, human, to another human, say Jenny over there. And I'm going to just cover what the virus might be doing once it's been emitted, when it travels, and when it hits the recipient. But first, I want to just try and cover why we're here. So some of my colleagues tell me that, you know, Julian, this is a hobby for you, isn't it? My day job is a physician and I run a virology lab. But in fact, it's not a hobby. I'll get called to a transplant ward or an antenatal clinic or an antenatal ward, and they'll say, Julian, this patient here had a visitor yesterday. The son had chickenpox this morning. What should we do? So I'll say, well, if it's chickenpox, it's easy. You screen everybody in the room for vis-a-vis IgG. You give immunoglobulin to those who are not immune, and hopefully they'll be okay. If they start to get symptoms after 8 to 10 days, you give acyclovir IV and hope they're okay. What's that? It's okay, I rescued myself. Antenatal clinic, same question. Julian, this lady came to see us yesterday, brought a child with her, chickenpox rash the next day. Who do we screen? Screen everybody who came in that duration, plus 10 minutes before, 10 minutes afterwards, because, in fact, we know vis-a-vis can linger in the air and still cause infection after the source is gone. And some of the work by Asano and colleagues from Japan have shown that virus can actually survive for up to 30 to 40 minutes. So this is not a hobby. I have to answer these questions and be fairly sure I'm giving the right advice. And so far in the last 14 years of being a virologist, you know, we haven't had any major issues, so I hope my instinct's as good as the evidence that I've just seen from my colleagues here. So let's imagine you're the virus now. Okay, you're going to be sneezed out, coughed out, talked out, breathed out in some way. I'm focusing purely on the human source here. We can cough, we can sneeze. Schlerin imaging has shown, these are from Gary Settles, some very nice cough plumes here. And this is the basic setup. Gary's is slightly different, but the principle's the same and very familiar to you engineers. So some questions to bear in mind while we go through this fantastic journey. How many drops, how big are those drops, and what viruses are carried in those drops when people sneeze and cough, breathe, and talk? And is that a useful statistic? Is that a useful quantity? Because the variation could be so wide, a generalization could be fairly useless. And clinicians do think differently from engineers. I don't need to know how many vis-a-vis viruses this kid emitted during his stay in the antenatal clinic or the transplant ward. I just know that he was there. Okay, I can't go in and model this. I have to give the advice immediately. So that the quantitation is useful for the papers, but when we're actually on the wards, we have to really think very quickly about what we're going to do. And it's going to be a belts and braces approach. So there have been lots of papers showing that airborne pathogens can be detected and identified in the air. We know that, and that my predecessors have shown this is possible. Certainly airborne infection can happen, airborne transmission can happen, but how much and how often does it happen? So I've got a series of videos here just to show you what kind of activity is going on when we breathe or talk or cough or sneeze. Oh, is it playing? Okay, so this is just me talking to my postdoc here, and you can see that most of the time our plumes, our speaking plumes don't mix, okay? We stay kind of on either side of our half, if you like, if you're looking at the football analogy. But occasionally they stray across. And if you look at the thermal plume here, it penetrates the thermal plume quite well. Okay, so the thermal plume is not very retentive. It doesn't contain our speaking plumes very well. This is just breathing. Now, this is slowed down a bit so you can see what's going on. So the nasal plume, when you breathe through the nose, also is not very well contained by the thermal plume. It spreads quite well. And if you imagine you're talking to each other across lunch or just even talking in the corridor, it's likely that your exhale flow will mix with your colleague's exhale flow and may even be carried up into your nasal breathing area by your thermal plume. And we did some dynamic studies looking at the wavefront. We found that the velocity of mouth breathing and nasal breathing are actually fairly similar, relatively low, but at least enough to cross that gap between two people who are talking to each other. This is very dark. So this is actually a cough. It's slowed down. Now, we found that the cough is actually not that fast. It's about 4 to 6 meters per second. Occasionally it gets to 10 to 14 meters per second. The idea here is to show you how different people cough. Okay, and most people cough in a fairly similar way. The head position is slightly different. The velocities are fairly similar. The volumes produced are actually fairly similar as well. A sneeze, sneezers have been estimated to be traveling at 100 meters per second. We only found relatively low speeds of around 4 to 8 meters per second. This is on a target mannequin. You can see that the mannequin gets a face full of this sneeze, which is why you turn your face away when you sneeze or cough at people. And this is postdoc Jovan, who's now very famous across the world. You can see that the sneeze produces large droplets of mucus, which obviously you want to avoid hitting other people with. Okay, so this is the airflow dynamic study showing the wavefronts moving about 4 to 8 meters per second. And in fact, I just had some emails with this Japanese group. They found pretty much the same parameters. And Gary as well with his PIV Schlerin imaging and measurement has also found about 8 meters per second for a cough. So it's actually not that high. So, and this is just showing the effects of the thermal plume. In fact, Dusan showed this earlier, and I can't show all of Dusan's videos, but he showed how the supply can actually suppress the thermal plume and maybe even retain some of that uprising aerosol from your colleague who's talking to you in your nasal breathing zone. So in fact, your thermal plume might also be, if you like, confounded by the ambient ventilation. This is a video from Conrad, which I think Bill showed earlier, the paper. And again, this is just another way of visualizing the thermal plume. And this is my team's effort here. And again, you can see the thermal plume seems to move quite quickly, but it's fairly easily penetrated by coughing, sneezing, and breathing. So now that we've got, with the virus, we've got out there, we're out floating around here, what kind of influences are going to drive us to the next susceptible recipient? Now, we've seen this slide a few times, or variations of it, and I strongly urge you to see Michael Gormley's talk tomorrow, where he will give you some revolting revelations about how your toilet drainage actually moves through a building. And some of these aerosols generated in the sewage system move very quickly. And we saw some consequences of that with Amur Gardens when the water traps dried out. And this can happen anywhere in the world with this system where the water traps actually dry out. These are real-life examples of failures of containment. This is from a hospital at UCLH. This is in a couple of hospitals in Sweden where MRSA and other wound infections occur in operating theaters where people move in and out of the operating theater too much. Okay, they open the door, they break the containment, they bring their own MRSA or skin SSRA into the environment, and they contaminate the wounds. So this kind of evidence is useful as an endpoint to why you're doing all these other ventilation studies. And this is just a schematic showing the various sources of what may actually affect your virus or airborne pathogen, TB, or fungal spores moving around the environment once it's left the source, thermal buoyancy effects, convection effects from hot equipment, human bodies, ventilation flows, and door opening motions, which my collaborator Petri has shown quite a few videos of recently. So sometimes the ventilation may actually not help. If you have cross-row ventilation, if you have natural ventilation, you can actually disseminate TB from one side of the ward all the way to the other, and vice versa. So how can you tell whether your ventilation is actually being more harmful than doing good? And of course, the different scenarios will differ. For example, in Singapore, they have a dedicated TB clinic, a TB ward. All they use is fans. They mount the fans behind the reception area, behind the doctor sitting in the clinic, and the fans just blow outwards, and it's nothing more sophisticated than that. And they've had very few, in fact, no skin test conversions in the last 10 years. Okay, these are probably just $10 fans. So if we focus on door opening motion, how can that affect the path of the virus? This is a small tank model that we built in Singapore, which gave us images like this. And these are qualitative images. Okay, there's some groups actually trying to quantify the dye density as a measure of potential viral load and air exchange across a doorway. But in fact, this kind of image is really enough to convince infection control teams that this is actually a risk. Hinged doors versus sliding doors may well be a risk. And just a quick video here to show you what we were doing. We looked at single and sliding hinged and single sliding hinged and double sliding and hinged doors. And you can see the effects are fairly dramatic. And these are scaled for the scale Reynolds number equivalents and normal walking speeds with full-scale human models. And we actually filmed colleagues walking through doors in the hospital and took the parameters from there as well. I've only shown the single hinge, single sliding, but the double hinge, double sliding are fairly similar. And this is a quad view here because you're looking at two sides of the door as well as above a bird's eye view as well. So just based on this, we don't need any figures, and the infection control team can see that this is a fairly dramatic difference in terms of the way that the air moves across the doorway. So then you get interactions of both human and environmental factors. And can we work together with the engineers from the clinical side to try and minimize these? And one good example of that is stop people going through the door so often, like in the operating theater. Stop medical students going through, stop doctors coming in just to have a chat, because they do that, come have a look, then go away again. And these can cause additional risks which are not necessary for the patient. Pig pen we've seen already. Bill's covered that. And this is a nice paper from Gary showing the effect of the wake. And Gary's looked at how the thermal plume actually changes to a wake at certain speeds. And this is a cute little video from Jack Edwards that I've been trying to get to come to this conference, but he couldn't make it, looking at multi-body flows in the Hajj, for example, or even in a football crowd. So if you can model this type of multi-body flow and come up with some kind of guideline for those people controlling or in control of these crowded areas, this would be very useful to prevent person-to-person transmission. This again is a video from Gary just showing the trailing wake that you can entrain as you walk in a straight line. And you can calculate that volume fairly easily. And then we try this in Singapore using first one person, then two people, and you can see the trailing wake there quite nicely, and you can see the interaction between the two, but it's only 2D, so these two are walking in front of each other, but you can see that clearly there's some interaction when they walk past each other, and some of that may actually enter your breathing zone. So this is one of my research assistants going back and forwards, and hopefully two of them coming together. Okay, so you can see, it's like the Lux advertisement from a few years ago when the girl's walking down the street and all the guys are smelling her Lux perfume. Of course, aeroplanes. I know I spoke to one of our participants here about the risk of enclosed areas, and airplanes are classics here with a 12-hour, 13-hour journey like I took here from Canada. This could be a confined space where you're risking contracting other people's infections. And Bill mentioned earlier that you're shedding several thousand skin cells per hour sitting in an aeroplane or an enclosed space. Of course, during SARS, there's oxygen masks. Nebulizers, were they a risk for disseminating airborne infection? We think it's possible. Of course, like Lydia says, it's always hard to prove unless you can sequence the viruses, but the viruses are the same anyway because it's a single genotype phenotype from the outbreak. It's hard to tell whether it came from the taxi driver before you got to hospital, the nurse who's looking after you, or patient next door in the bed. And even next-gen sequencing may not solve that problem with an emerging infection, which is a monotypic type of infection. So what can we do about this? Well, in clinical medicine, again, we're very simple people. We basically use a very crude approach, a very much belts and braces approach. We just screen everybody, test everybody, prophylax everybody. Okay, we don't have time to go away and model it and say, well, person A here probably got the highest exposure, person B here didn't, so we don't need to prophylax person B, just do person A. But to be honest, we want to be safe. If it's meningococcal exposure in a lecture theatre to students, you give all those in the vicinity rifampicin, okay? So you're not going to take the chance, based on your quick model, that you might, just in case you miss somebody out. So everyone's familiar with this. There's engineering controls, which hopefully is what we're talking about here. Admin controls, which maybe no one listens to, that's a problem. And there's personal protective equipment here, which doctors and nurses always fight with the administrators, like, we need an N95 mask, where's the evidence? We don't have the money, we want to protect ourselves. So I mentioned this earlier in the week. Singapore has the money. They can build beautiful sliding door containment rooms, antechamber here. This is a TB ward. This is an antechamber which does not open the inner door until the air inside has been exchanged, and vice versa when you go out. They built a $50 million SARS unit after SARS, and they use it for all sorts of potential airborne infected patients. Admin controls, well, you can tell people to do things, but they don't listen, they don't do what they're told. So eventually you have to maybe go down to PPE, and it depends on the severity of the illness. If you're dealing with seasonal influenza, people aren't going to be very stringent about following these guidelines. If you're dealing with Ebola or smallpox or avian influenza, where the mortality is 60%, you'll see a change. They do what they're told. And then what is the next step? Now your virus is like way out here, not quite at Jenny, but almost there. How are you going to tell whether Jenny actually gets the virus? Okay? Whether she actually inhales the virus, whether it actually causes an infection, could be asymptomatic or symptomatic, so whether that causes disease or not. Recent work from Don Milton has suggested that our diagnostic swab, which can be 10 to the 8 to 10 to the 12 copies per mil when you swab from the mouth, that may not translate to the droplets expelled from the mouth during certain respiratory activities. And this is an interesting question. What happens, where does the virus go? It should be in that droplet at this concentration, but where does it go? Or is it non-viable? Has it become inactivated by the sheer stress of the sneeze or the cough or the environmental exposure? Then dispersal factors, so you saw when this volunteer coughed into a mannequin, not all the droplets will hit the mannequin. Okay, so if you collect all the droplets like Don Milton does in his G2 study, hopefully that will overestimate the exposed load that most of us get, so in fact, we don't get infected all the time. And of course, that only depends if you know the infectious dose, which I'll get to in a minute. So you can see here the close-up cough. I'll just show you this first. Clearly the mannequin gets a face full of this cough. Now this is very unrealistic because you don't cough in people's faces unless you really don't like somebody. Normally you turn your head away. If you look at the far distant cough, this is like 1 meter away. Like if you cough at your friend over lunch, your friend won't thank you for that, but normally you turn away, you cover your mouth. So again, this is slightly artificial, but you can see from the picture here, the plume does actually go across and hit the face of the mannequin, but much less so than here. And then how do we know that the virus actually gets inhaled by Jenny, for example? And Jan, one of Ugoli's PhD students, is working with me and Warren Finley, who's an expert on drug delivery, aerosol drug delivery in Canada, University of Alberta. And they've actually created these 3D models from actual patient CT scans. Okay, so they build the layers, and then they convert into 3D printing instructions and build these models, and they have the full anatomy of nasal cavities, all the different airways inside inside the skull. And we've been working with Jian and Yugor to try to see how much of this air is actually re-inhaled. So this is the first step. Can we assume that everything we exhale is available as a source transmitting cloud? And there's been a study showing that 17% might be re-inhaled. Well, is that true? And we found that it's not true. We found that very little of the plume is actually re-inhaled. And that's good because the Wells-Rayleigh equation assumes that kind of you get to a steady state after a certain time, and we assume that everything that's exhaled will become part of that steady state for infectious disease modeling. And clearly there's no re-inhalation of this plume here. And then using PIV, Jian's actually managed to count the number of particles re-inhaled using this multi-layered laser sheet system. And again, very few particles are re-inhaled. And the reason I'm showing this is because Jian's giving his talk tomorrow, and most of you might have left, so he kind of let me show this so that it reaches a wider audience. So it's a very nice system, and it's an anatomically correct model, and we hope that these results will be quite useful for modelers and maybe reveal some more light about the inhalation process of the end of the pathway of this fantastic voyage. So the final problem is that how can you know what the infectious dose is for individuals, for every organism? And you can't. And everybody's different because you have different immunological histories, different exposure histories. I was very interested to see Bill's comment about the inhaled pathway of the respiratory tract. But of course, that depends where the virus can cause infection and disease. Really depends on where it lands and where the available receptors are. So for influenza, the 2,3 salic assay receptors are not all over the respiratory tract. They're more concentrated in some places than the other. And in fact, even influenza, the receptors are slightly different. The distribution's different. With the other organisms here, some people might have had previous vaccination, some people may have had previous exposure through their work, and they might be relatively immune to some of these organisms, then they may require a higher infectious dose. So really, what I wanted to cover is the whole pathway from source production of the virus, what kind of environmental effects will affect the pathway of the virus, and how the virus can be inhaled, and actually what you need to know to see whether that virus causes infection plus or minus disease. And a lot of this stuff on this page we've actually looked at, and Bill and Lydia presented a lot of information and data about this, so I don't need to do that. That wasn't the plan, by the way, but I'm glad they did that. And now we need a slightly more kind of focused look on really what's happening at a level that we can actually intervene on. Why don't all the droplets carry all the viruses we expect them to for a given volume? What are the immunological factors that may actually not give rise to symptomatic infection? How long is the shedding going to be? And there's people with partial or full immunity, if they do get infected asymptomatically or not symptomatically. And then how can you actually intervene to reduce this risk to our patients that we see every day in the hospital? And we can't go in and just model everything, come back to the patient and say, you know what, we're going to do this, because it's too late. Okay, we need to have these answers straight away. So I can say to my nurses, this is what we're going to do. I know we can do this because it's in the guidelines, because the data's there, and I don't have to think about it much more than that. Just a whole list of collaborators here. So some of you know I've moved around a bit, so I want to thank primarily the Singapore group. So I know Guopwai's here. A lot of the images I showed couldn't have been produced without his help and his support in his lab, and all the funding from the Singapore councils. And then Yugor Lee, of course, his postdocs and PhD students. Hanno Kaskala and the Finnish group who collaborated with the Singapore group and did all the door-opening full-scale modeling. UK Ian Ians, Peter Wilson Cathnox, who's here as well, and Andre and Christian, the postdocs who did all the CFD modeling. Gary Settles, of course, who helped me set up the mirror. Jack Edwards, who had some nice vortex fan models. And Warren Finley, the latest team that we collaborated with, who gave me the 3D models. Thank you.
Julian, Professor Tang, for a wonderful and marvelous presentation, illustration of how environmental and human factors are very much and heavily intertwined together in terms of understanding the sciences of infectious control, as well as how we can effectively, economically feasible managing the issue in the future. And thank you again, Professor Tang.